Our group members were Georgia Bowman, Georgina Peckin, and Melody Hamilton, and we are presenting on feeding and eating disorders, focusing on anorexia nervosa. Anorexia nervosa is a mental health disorder characterized by severe intentional weight loss in an individual. The DSM-5 classifies anorexia nervosa as a restriction of food intake leading to an individual being significantly underweight relative to their normal or expected weight in the context of age, sex, development, and health, paired with an intense fear of weight gain and/or behavior that interferes with weight gain, underscored by a disturbance at one's weight or shape. There are two subconditions of anorexia nervosa, restricting type and binge eating type or purging type. Restricting type is the classic presentation. However, some individuals also engage in binge eating followed by purging episodes in addition to these restricting behaviors. The DSM-5 distinguishes between these subtypes by determining if a binge eating or purging episode has occurred in the last 3 months. If yes, the individual is considered to have binge eating purging type anorexia nervosa. If no, they are considered to have restricting type anorexia nervosa. Purging can consist of self-induced vomiting, use of laxatives, or diuretics. The diagnostic criteria includes a measure of severity, which divides anorexia nervosa cases by the body mass index of the patient, identifying mild, moderate, severe, and extreme anorexia nervosa. Whilst it is necessary to maintain a clear, valid, and reliable diagnostic criteria for mental health disorders, the clinical reality is that no two patients present in the same way, and it is therefore imperative that healthcare clinicians are cognizant of the variations in presentations that they may be faced with. Additionally, it's relevant to be aware of signposts or red flags to indicate the presence of specifically an eating disorder. The DSM-5 is a useful diagnostic manual in the psychological setting, but pre-hospitally, it's important to be conscious of variations in presentation and the effect of comorbidities. In the pre-hospital setting, patients who are diagnosed with anorexia nervosa and have an altered level of consciousness and/or difficulty walking are considered to require hospitalization. The difficulty walking can arise from several causes, such as muscle weakness, dehydration, infection, fatigue, and cardiac issues, as a result of the patient being severely underweight or undernourished, or as a result of over-exercising to lose weight. Again, not every patient is going to present visually as expected, and it's relevant to recognize that patients may not appear drastically underweight, but can still be severely undernourished and have all the associated comorbidities. For people who suffer from anorexia nervosa, they are characteristically plagued by a feeling of disgust or disturbance at their body weight or shape, which fuels a fear of weight gain. In the pre-hospital setting, we see this fear of weight gain manifest in many physical capacities. Physiologically, patients experience hypertension, arrhythmias, osteopenia, and metabolic instability. Individuals who engage in purging behaviors are often present with electrolyte imbalances and hyperkeratosis, as well as enamel erosion, parotid gland enlargement from excessive vomiting and gastric acid, scarring on hands from self-induced vomiting, known as Russell's sign, and markedly fluctuations in weight when binging and purging. Cognitively, the mental health impacts of anorexia nervosa are debilitating. The condition of diagnosis that specifies a fear associated with weight gain preempts the presence and development of depression and anxiety, and often induces suicidal thoughts. This is worsened by the mental health cycle of body dysmorphia that ensures that an individual will never be satisfied with weight loss. There will always be a significant mental disturbance regarding their weight or body image. Furthermore, there is a significant amount of stigma associated with anorexia nervosa, and many sufferers report feeling shame associated with the condition, as well as feeling isolated and unable to escape their condition, particularly as there are often highs associated with successful weight loss, which can lead to a pursuit of further weight loss to escape the lows of the condition. It is a mental health condition that is often visually noticeable, which can compound the stigma that patients are treated and managed with. Individuals experiencing anorexia nervosa face many challenges in dealing with their mental health, which can be exacerbated by the clinical management of the disease complications. Often medical care and mental health care are not adequately intersected, and patients can be faced with management that either caters too heavily to their mental health condition and fails to correct the medical implications of the condition, or vice versa. Patients can be faced with medical care that adequately manages their physical symptoms without addressing the underlying mental health. It is widely agreed that management of eating and feeding disorders should be multidisciplinary. Further research has demonstrated that those experiencing anorexia nervosa may have perceptual and cognitive experiences that differ from those not suffering from anorexia nervosa. This has implications in the pre-hospital setting, as descriptors of pain or body perception may differ from the norm. That is to say that specifically for paramedics, trying to determine a normal state of being for reference of care can be difficult, as patients may have cognitive or perceptual disturbances in their body image, mental state, or general state of being. This is relevant in long-term treatment of the disorder, but largely can be seen to affect initial management.
Medications to treat the mental illness itself are not relevant in the pre-hospital setting. Treatment surrounds somatic complications of low weight instead. The primary needs of an acute anorexic patient are calories, vitamins, fluids, electrolytes, and warmth, rather than pharmacological treatment. The current first-line treatment for people with anorexia nervosa out of the pre-hospital setting is cognitive behavioral therapy. SSRIs have been used to treat anorexia with little success except in the case of comorbidities. In the pre-hospital setting, acutely anorexic patients may resist dextrose strips or glucose paste, so medication can be useful to manage distress and anxiety causing resistance to feeding. Anorexia often also presents with exercise compulsion and agitation, for which sedative medication like lorazepam or midazolam can be helpful, though risks must be weighed up against benefits, as physically compromised patients are more at risk of cardiovascular complications from these medications. Regarding long-term improvement, research conducted using antipsychotic medications such as olanzapine found little difference between control and placebo groups based on weight gain and improved outcomes on the Eating Disorders Inventory Scale. It has been found to improve weight and psychological factors in case reports, but not in meta-analyses. Our fact sheet primarily focuses on olanzapine, as research has been conducted with olanzapine in both acute and long-term contexts, but not other antipsychotics like midazolam in relation to anorexia. Olanzapine is also relevant with promise in helping mental health subjects, as it is currently in the process of being added to Ambulance Victoria's mental health, Ambulance Victoria's guidelines. Antipsychotic drugs have multiple effects on the body through acting on different neurotransmitter systems, including antagonizing D2-type dopaminergic, serotonergic, histaminergic, cholinergic, and adrenergic receptors. Side effects of blocking the D2 pathway are confusion, memory impairment and delirium, dizziness in high doses, and in high doses movement disorders such as dystonia. Blockage of pathways leading to the hypothalamus and pituitary gland increase levels of certain hormones such as prolactin, while decreasing FSH, leading to decreased bone density, weight gain, erectile dysfunction, impaired libido, and amenorrhea. Weight gain is a side effect of olanzapine due to its modulation of metabolism, making it useful in treating anorexia. However, studies have yet to find this statistically significant. These side effects are consequent to regular and long-term therapeutic use, not in the pre-hospital setting used for sedation. Regarding drug interactions, the sedative and the hypotensive effects of benzodiazepines and olanzapine appear to be additive, particularly with parenteral use, so there must be a gap between doses. Olanzapine also interacts with some antidepressants. Fluvoxamine is an SSRI often used to treat OCD and is known to inhibit olanzapine first-pass metabolism, with an 84% increase in peak serum concentrations of olanzapine found when given together over 8 days to 10 healthy male smokers. Smoking also interacts with olanzapine by affecting clearance due to also acting on the CYP1A2 enzyme, leading to a 23% higher clearance in smokers than in non-smokers. For this reason, dosages must be adjusted for patients who smoke. Olanzapine overdose presentations vary due to the multi-receptor action and depending on the dose. Commonly, patients present with neurological symptoms, including altered level of consciousness and coma, as well as extrapyramidal symptoms and QT prolongation. And now here are the common mental status examination findings of an anorexic patient. For appearance, they'll often be frail, thin, with dry skin that can fissure and bleed, have bluish discoloration on their fingers, nose, and ears, which is called acrocyanosis, are cold to touch, have fine downy hair on their body, bruises, appear fatigued, and may have bloating due to gastroparesis, which is delayed emptying of the stomach. They may have secretive behavior, including social isolation, obsessive behavior, compulsive behavior, and they may also be agitated. For mood, they often feel depressed and have anxiety and low self-esteem. And for affect, they often appear sad, worried, flat, and their affect is often not congruent as described. They may say they feel fine, but they're really struggling. The thought form and process, they may have impaired concentration affecting their thought due to their lacking nutrition and being underweight. They may have normal thought, or they may have normal thought form, but what they're saying may seem illogical. For example, thinking they're overweight when they're critically underweight. For thought content, they often have selfish thoughts. Narcissism is evident through denial of need for food, symbolically representing a denial in the need for relatedness and dependence. There's a focus on food, exercise, body appearance, weight concern, and sometimes thoughts of suicide and self-harm. For perception, body dysmorphia is a key component of anorexia nervosa. And for insight and judgment, they're often in denial of the disease, or at least the extent of it, or they understand that they have it, but they may be reluctant to seek help and especially gain weight. For paramedic communication strategies, paramedics should be aware that patients with eating disorders often hear a sentence differently to how it's being said. For example, "You look so healthy" to the normal person would be a compliment, but to a person with anorexia, it may be understood as "you've gained weight," which can be triggering to them. It is important to create an atmosphere that avoids fueling the disorder. Additionally, negative self-esteem and body image are core components of anorexia, so patients may struggle with exposing their bodies during assessment. Care should be taken when obtaining consent and conducting assessments. According to Levine 2016, professionals need to be aware of not only what they say, but also their body language. If they appear not engaged, bored, or dismissive of the problem, or violate the patient's safe space, individuals who are already ambivalent about seeking treatment may flee from an uncomfortable interaction and not pursue potential treatment.
Anorexia nervosa can have complications throughout all major organ systems that paramedics need to consider carefully, as they range from mild to lethal. Cardiac irregularities are often present in AM patients as a result of physiological disturbances. Hypotension commonly occurs as a result of malnutrition and dehydration. Pericardial effusion and decreased left ventricular size are structural abnormalities also common in AM patients. Cardiac tamponade is a rare but potential condition which can arise from pericardial effusion. Low BMI in an AM patient is a risk factor for hypoglycemia, and blood glucose level assessment should be conducted by paramedics. If hypoglycemia is left untreated, there can be severe complications, including seizures, loss of consciousness, and hypoglycemic coma. As a paramedic, it is important to consider which type of AN your patient is experiencing. Russell's signs is detected on some patients with bulimic type anorexia nervosa. Russell's signs involves abrasions, callosities, and scarring on the dorsal portion of the patient's hands. These signs are likely to indicate self-induced vomiting. Self-induced vomiting can cause many electrolyte imbalances, which can have detrimental effects on the patient's health. Self-induced vomiting can also lead to teeth or enamel erosions, which should be considered upon assessment. Individuals with anorexia nervosa have increased susceptibility to experiencing internalizing disorders. Increased levels of discomfort in their own body and distorted views can lead to social anxiety. Decreased self-esteem and negative views can be heightened with depression, leading to more restrictive behaviors. Self-harming and suicidal behaviors can present, thus paramedics need to consider the safety of leaving a patient at home. Anorexia nervosa, being a psychiatric condition, means recovery and treatment is targeted at both the physical and mental health of the patient. The initial treatment for an anorexia nervosa patient is to restore weight and to improve their nutritional status. Nutritional restoration contributes to the improvement of cognitive function, allowing psychological interventions to be more successful. During weight restoration, an AN individual often becomes hypermetabolic and requires substantial caloric intakes to be able to maintain a safe weight after recovery. Restoration of weight and nutritional status should occur at a slow and gradual rate, which should only be increased as tolerated. If an AM patient increases their intake too rapidly, they are at risk of refeeding syndrome. Cognitive behavioral therapy is a common psychological treatment for AN patients. It focuses on several stages throughout, involving the patient's motivation, cognitive perception, relapse prevention, and external issues. Family therapy is another form of treatment which is effective for adolescents. Recovery is influenced by duration, illness, age of onset, and body weight. It is common that patients will never fully recover mentally and physically from AN. Once recovered, they may possess characteristics of the condition, including perfectionism and continuing to maintain a BMI below the average population. Treatment is often successful in hospitals to restore the weight of AN patients. However, they're at higher risk of relapsing. Support organisations can assist and encourage those experiencing AN to reach out. The Butterfly Foundation has counsellors who are trained and experienced in discussing eating disorders. The Foundation provides patients and family members with guidance on treatment, strategies, and support and connections with alternative services and specialists. Paramedics should provide an in-depth IMIST-AMBO, including other key information specific for AM patients. There are often mixed feelings towards seeking help, and patients often go prolonged periods without treatment. Knowledge of who made the call to the ambulance can indicate whether the patient is in denial or ready to seek help. Patients who do not make the call themselves are less inclined to want treatment due to their denial and lack of awareness. Health professionals should also be made aware as to whether the patient has received treatment previously. The initial meeting with a healthcare professional is important in influencing the patient's attitude towards seeking help. Poor communication with patients can be detrimental to their recovery and may result in discontinuation of help-seeking behaviours. The reasoning for the call alters the requirements and the urgency of treatment needed. The call will commonly be due to physiological impacts of anorexia nervosa, including fainting, cardiac irregularities, kidney failure, or fractures due to brittle bones. It is vital to remember, although anorexia nervosa is the overarching condition, it may not be the initial reason for their hospitalisation. Underlying medical conditions and complications the patient may be experiencing should also be shared with medical staff. Impaired liver functioning is one condition which commonly occurs. It plays an essential role in drug metabolism and may lead to alterations in drug dosages.
And now we will show a short video to help hone our understanding of a potential experience of patient with anorexia nervosa.